Chapter 2, Erythropoiesis and Anemia. Blood cells. All the circulating blood cells derive from pluripotential stem cells in the marrow. They divide into three main types. The most numerous are red cells, which are specialized for carriage of oxygen from the lungs to the tissues and of carbon dioxide in the reverse direction, Table 2.1. They have a 4-month lifespan, whereas the smallest cells, platelets involved in hemostasis, circulate for only 10 days. The white cells are made up of 4 types of phagocyte, neutrophils, eosinophils, basophils and monocytes, which protect against bacterial and fungal infections, and of lymphocytes, which include B cells, involved in antibody production, and T cells, CD4 helper and CD8 suppressor, concerned with the immune response and in protection against viruses and other foreign cells. White cells have a wide range of lifespan, Table 2.1. The red cells and platelets are counted and their diameter and other parameters measured by an automated cell counter, Figure 2.1. This also enumerates the different types of white cell by flow cytometry and detects abnormal cells. We each make approximately 1012 new erythrocytes, red cells, each day by the complex and finely regulated process of erythropoiesis. Erythropoiesis passes from the stem cell through the progenitor cells, colony-forming unit granulocyte, erythroid, monocyte and megakaryocyte, KFU-gem, burst-forming unit erythroid, BFU, and erythroid CFU, KFU, Figure 2.2, to the first recognizable erythrocyte precursor in the bone marrow, the prenormoblast. This process occurs in an erythroid niche in which about 30 erythroid cells at various stages of development surround a central macrophage. The prenormoblast is a large cell with dark blue cytoplasm, a central nucleus with nucleoli and slightly clumped chromatin, Figure 2.2. It gives rise to a series of progressively smaller normoblasts by a number of cell divisions. They also contain progressively more hemoglobin, which stains pink, in the cytoplasm. The cytoplasm stains paler blue as it loses its RNA and protein synthetic apparatus, while nuclear chromatin becomes more condensed, Figs 2.2 and 2.3. The nucleus is finally extruded from the late normoblast within the marrow and a reticulocyte results, which still contains some ribosomal RNA and is still able to synthesize hemoglobin, Figure 2.4. This cell is slightly larger than a mature red cell, and circulates in the peripheral blood for 1 to 2 days before maturing, when RNA is completely lost. A completely pink staining mature erythrocyte results, which is a non-nucleated biconcave disc. One prenormoblast usually gives rise to 16 mature red cells, Figure 2.3. Nucleated red cells, normoblasts, are not present in normal human peripheral blood, Figure 2.4. They appear in the blood if erythropoiesis is occurring outside the marrow, extramedullary erythropoiesis, and also with some marrow diseases. Erythropoietin. Erythropoiesis is regulated by the hormone erythropoietin. Erythropoietin is a heavily glycosylated polypeptide. Normally, 90% of the hormone is produced in the peritubular interstitial cells of the kidney and 10% in the liver and elsewhere. There are no preformed stores, and the stimulus to erythropoietin production is the oxygen, O2, tension in the tissues of the kidney, Figure 2.5. Hypoxia induces synthesis of hypoxia-inducible factors, HIF1 and which stimulate erythropoietin production and also new vessel formation and transferrin. Figure 2.2. Erythroblasts, normoblasts, at varying stages of development. The earlier cells are larger, with more basophilic cytoplasm and a more open nuclear chromatin pattern. The cytoplasm of the later cells is more eosinophilic as a result of hemoglobin formation. Figure 2.3. The amplification and maturation sequence in the development of mature red cells from the prenormoblast. Figure 2.4 Comparison of the DNA and RNA content, and marrow and peripheral blood distribution, of the erythroblast, normoblast, reticulocyte and mature red blood cell, RBC. Receptor synthesis, and reduces hepcidin synthesis, increasing iron absorption. Von Hippel-Lindau, VHL. Protein breaks down HIFs and PHD2 hydroxylates HIF1 allowing VHL binding, figure 2.5. Abnormalities in these proteins may cause polycythemia, see Chapter 15. Erythropoietin production therefore increases in anemia, and also when hemoglobin for some metabolic or structural reason is unable to give up O2 normally, when atmospheric O2 is low or when defective cardiac or pulmonary function or damage to the renal circulation affects O2 delivery to the kidney. Erythropoietin stimulates erythropoiesis by increasing the number of progenitor cells committed to erythropoiesis. The transcription factor GATA2 is involved in initiating erythroid differentiation from pluripotential stem cells. Subsequently, the transcription factors GATA1 and FOG1 are activated by erythropoietin receptor stimulation and are important in enhancing expression of erythroid-specific genes, for example globin, hem biosynthetic and red cell membrane proteins, and also enhancing expression of anti-apoptotic genes and of the transferrin receptor, CD71. Late BSFU and CFU, which have erythropoietin receptors, are stimulated to proliferate, differentiate and produce hemoglobin. The proportion of erythroid cells in the marrow increases and, in the chronic state, there is anatomical expansion of erythropoiesis into fatty marrow and sometimes into extramedullary sites. In infants, the marrow cavity may expand into cortical bone resulting in bone deformities with frontal bossing and protrusion of the maxilla, cp. 78. Conversely, increased O2 supply to the tissues, because of an increased red cell mass or because hemoglobin is able to release its O2 more readily than normal, reduces the erythropoietin drive. Plasma erythropoietin levels can be valuable in clinical diagnosis. They are high in anemia unless this is due to renal failure and if a tumor secreting erythropoietin is present, but low in severe renal disease or polycythemia vera, figure 2.6. Figure 2.6 The relation between erythropoietin, EPO, in plasma and hemoglobin concentration. Anemias exclude conditions shown to be associated with impaired production of EPO. Hem synthesis occurs largely in the mitochondria by a series of biochemical reactions commencing with the condensation of glycine and succinyl coenzyme A under the action of the key rate-limiting enzyme aminolevulinic acid, ALA, synthase, figure 2.7. Pyridoxal phosphate, vitamin B6, is a coenzyme for this reaction. Ultimately, protoporphyrin combines with iron in the ferrous, Fe2+, state to form HUM, figure 2.8. Indications for erythropoietin therapy. Recombinant erythropoietin is needed for treating anemia resulting from renal disease or from various other causes. It is given subcutaneously either 3 times weekly or once every 1 to 2 weeks or every 4 weeks, depending on the indication and on the preparation used. Erythropoietin alpha or beta, dabpoetin alpha, a heavily glycosylated longer-acting form, or MISA are the longest-acting preparation. The main indication is end-stage renal disease, with or without dialysis. The patients often also need oral or intravenous iron. Other uses are listed in Table 2.2. The hemoglobin level and quality of life may be improved. A low serum erythropoietin level prior to treatment is valuable in predicting an effective response. Side effects include a rise in blood pressure, thrombosis and local injection site reactions. It has been associated with progression of some tumors which express EPO receptors. The marrow requires many other precursors for effective erythropoiesis. These include metals such as iron and cobalt, vitamins, especially vitamin B12, folate, vitamin C, vitamin E, vitamin B6, thiamine and riboflavin, and hormones such as androgens and thyroxine. Deficiency in any of these may be associated with anemia. Hemoglobin. Hemoglobin synthesis. The main function of red cells is to carry O2 to the tissues and to return carbon dioxide, CO2, from the tissues to the lungs. In order to achieve this gaseous exchange, they contain the specialized protein hemoglobin. Each molecule of normal adult hemoglobin A, HbA, the dominant hemoglobin in blood after the age of 3 to 6 months, consists of 4 polypeptide chains, 22, each with its own hem group. Normal adult blood also contains small quantities of 2 other hemoglobins, HbF and HbA2. These also contain chains, but within chains, respectively, instead of Table 2.3. The synthesis of the various globin chains in the fetus and adult is discussed in more detail in Chapter 7. Figure 2.7. Hemoglobin synthesis in the developing red cell. The mitochondria are the main sites of protoporphyrin synthesis. Iron, Fe, is supplied from circulating transferrin. Globin chains are synthesized on ribosomes. Aminolevulinic acid, coenzyme A. A tetramer of 4 globin chains, each with its own hem group in a pocket, is then formed to make up a hemoglobin molecule. Figure 2.9. Hemoglobin function. The red cells in systemic arterial blood carry O2 from the lungs to the tissues and return in venous blood with CO2 to the lungs. As the hemoglobin molecule loads and unloads O2, the individual globin chains move on each other. Figure 2.9. The 11 and 22 contacts stabilize the molecule. When O2 is unloaded, the chains are pulled apart, permitting entry of the metabolite 2,3-diphosphoglycerate, 2,3-DPG, resulting in a lower affinity of the molecule for O2. This movement is responsible for the sigmoid form of the hemoglobin O2 dissociation curve, Figure 2.10. The P50, that is the partial pressure of O2 at which hemoglobin is half saturated with O2, of normal blood, is 26.6 mm of mercury. With increased affinity for O2, the curve shifts to the left, that is the P50 falls, while with decreased affinity for O2, the curve shifts to the right, that is the P50 rises. Normally, in vivo, O2 exchange operates between 95% saturation, arterial blood, with a mean arterial O2 tension of 95 mm of mercury, and 70% saturation, venous blood, with a mean venous O2 tension of 40 mm of mercury, Figure 2.10. The normal position of the curve depends on the concentration of 2,3-DPG, H+ ions and CO2 in the red cell and on the structure of the hemoglobin molecule. High concentrations of 2,